Hello and welcome. I'm Al-Salihi and you're watching Dr. Sugar. Welcome back to another video in the series that's meant to prepare you for the MRCP PACES exam. Today's case will be a Station 1 case. It's one of the most frequently encountered cases in the MRCP PACES exam, and that is chronic liver disease. As you know, in any clinical examination station, you're only given a couple of lines about the patient, and then you're expected to examine the patient and make your own conclusions about the diagnosis and what the patient may need. Without further ado, let's start with the case. Now, let me remind you of something. Although this is very obvious, but you have to keep in mind, this is an abdominal examination station. Therefore, whatever the patient has to be due to something that can only be attributed to an organ in the abdomen. So most likely, it is either a liver problem or a renal problem. Now, you enter the room and you have a look at the patient from the end of the bed, and the patient seems slim. They look almost cachectic. You can clearly also observe that they've got a big tummy. This should sound alarm bells in your brain. This big tummy in an abdominal examination station is ascites. Therefore, the patient either has chronic liver disease due to whatever cause, or has some sort of chronic kidney disease that causes protein losing nephropathy. As we always say, because common things are common, therefore chronic liver disease is much more common. Just think of the number of people may abuse alcohol. Think of the number of people with NASH. Think of the number of people with hepatitis C or hepatitis B. And there you go, you have the answer. So back to the case. Part of your preparation for any of the examination stations, you should perfect your routine. You should know exactly what you're going to do like a robot. And then you try to pick up the signs as you go through your routine and think of what the cause may be. But you can't be in the middle of the examination trying to think of the next step in the examination. You have to know exactly where you are in your routine, examining that part of the body and what comes next. As I always advise, when you examine a patient with any problem anywhere in the body, you can either start by examining that part of the body, or you can do a general examination to look for manifestations of diseases that can be originated from that part but have systemic effects. Therefore, you want to start from the abdomen itself, that's fine. You want to do a quick general examination, head, hands and feet, and then go to the abdomen, then that's possible as well. Note, for chronic liver disease, you want to have a look at the trunk in general, so you want to look at the chest as well. So the choice is really yours. If you want to start from the abdomen, or if you want to start with the general systemic examination. So my preference is to start from the head for someone with chronic liver disease. So looking at the head, what are you going to be looking for? So the first thing you'd be seeing, and this is something you'd see only if the bilirubin is high enough to cause it, that's jaundice. You need a bilirubin that's at least twice as high as the upper normal limit. You could see wasting in the face muscle. You could see parotid enlargement, although this isn't very common to see. Examining the neck, that could help you with assessing the fluid status of the patient, but can also help you with examining for any lymphadenopathy that can be associated with the pathology causing the chronic liver disease. Don't waste too much time there. Go down to the chest. In the chest, you'd be looking for spider nevi. You'd be looking for gynecomastia. Now you can examine the hands. There are a number of things that you can look for in the hands. If you're starting with the nail beds, you can look for leukonychia, you can look for cholonychia. And remember, anemia could happen in chronic liver disease due to a number of causes. It can be either a GI loss, it can be a nutritional problem, or it can be because of suppression of bone marrow. Look for dipteran contracture, look for pulmonary edema, and always check for hysterexis. If the patient has hepatic encephalopathy, then you're expecting to find a flapping tremor. Now in the legs, you could look for evidence of coagulopathy. You could be seeing petechiae, you could be seeing ecchymosis, and you could also look for bilateral leg edema associated with low albumin associated with the chronic liver disease. Now go back to the most important part of the examination, that's the abdominal examination, because remember, it should take you only a minute or minute and a half to do the rest of the things. You need to focus on the abdomen, because after all, that's what you're going to get marked on, and that's where you get the actual diagnosis from. So first thing, you need to determine if the abdomen is actually distended. How do you do that? You've got two things to look for. First one, umbilicus can be everted. Second thing, the patient would have flank fullness. Examination is always the same. You've got your 4 steps of examining any part of the body: inspection, palpation, percussion and auscultation. An inspection for abdominal examination should happen from the end of the bed. From end of the bed you could look for symmetry, you could look for pattern of abdominal movement with respiration. Going back to the right side of the patient to look for the signs that you could just see, like caput medosa, although that's not very common to see nowadays because most of the patients would be treated early on, but you could still see dilated veins. You're looking for scars, you're looking for visible pulsations, you're looking for a possible drain that's in situ. Now palpation is very important obviously. You can do your superficial and deep palpation separately, you can kind of do them together, whichever way you prefer. Remember the organs that you're palpating for. You're palpating for the liver, you need to get the liver span. Even approximately you can do it with your fingers. If you've got a tape measure you can use that. Check for the spleen, make sure you turn the patient to the right side if you can't feel it, if the patient is in the recumbent position. Now if your patient's got a big ascites, examining in the classical way may not be very easy. What you could use instead is ballottement. That way you could tell where the liver edge is, if it's enlarged, if there is anything you could feel at all. Examine for the kidneys as well. Now coming to a very important part of the examination is to determine whether the patient actually has ascites. The distension is fluid. 2 maneuvers you could use for this: shifting dullness to percussion, and the second thing is transmitted thrill. Shifting dullness to percussion works better with moderate ascites, while transmitted thrill works better with large volume ascites, but no harm in trying both. Now you can auscultate and have a listen for the hepatic hum. Remember, there are certain signs that are more frequently seen with certain causes of chronic liver disease. Dipteran contracture is more common with alcoholism, for example. You don't want to miss someone who's got all their bodies tattooed. That's something you need to mention because that could suggest hepatitis. If the patient has joint involvement, if they've got arthritis with everything in chronic liver disease, or if they've got an insulin pump, they look like they're diabetic, then you may think of hemochromatosis, particularly if they've got hyperpigmentation as well. Kaiser Fleischer rings, you could see them in Wilson's disease, but this isn't something very common. I mean Wilson's disease in general, so keep it in mind, but you don't need to waste time looking for it. Now you've concluded your examination, that's great news. By now, you should know what the diagnosis is. You're presenting your finding now. The way to present your finding is to mention the important positive ones, and then the important negative ones, and then give them the diagnosis. Don't bore them with every single thing you've done and how you've done it. For example, saying on an inspection, I saw this, I didn't see this. That's not what they're looking for. They want to hear something like the patient is jaundiced from the end of the bed. They want to hear something like the patient's got gross ascites. They want to hear something like the patient has evidence of hypoalbuminemia, or the patient is in a state of fluid overload, etc., etc. Now the fun part begins. With chronic liver disease, one question is guaranteed, you're always going to get it. They will ask you about the causes. My advice in general, to memorize things, and this is useful for medical students, it's useful in any stage in your life. Always categorize. Don't try to remember all causes of any given disease, all of it as a list. That's impossible to do. You'll always forget few of them. So many diseases you can't remember everything. So categorize, categorize, categorize. In general, there is a set number of categories into which causes could fall. Things can either be congenital, they're either drug related, they're either infectious, they're either metabolic, or they're autoimmune. For chronic liver disease, I think the best way to do it is to start with alcohol and consider it a drug. and then mention the other drugs with it. And you want to memorize a few examples of drugs that can cause chronic liver disease. They normally should be drugs that are used for chronic illnesses, such as methotrexate, such as isoniazides, such as phenytoin. Second thing you want to mention is infections, and what you're really thinking of is viral infections, because viral infections are the ones that can give you chronic liver disease. So it's your Hep B, Hep C. Now you can go either to autoimmune or you could go to metabolic causes. Autoimmune is slightly more common, so you want to say, for example, primary biliary cirrhosis, primary sclerosing cholangitis, or autoimmune hepatitis itself. When it comes to metabolic causes, remember, NASH is one of the metabolic causes, and it's a very important one. Do not forget mentioning this in an examination, okay? Other metabolic causes are alpha-1-antitrypsin deficiency, Wilson's disease, hemochromatosis, cystic fibrosis. Another very important and common question is the causes for decompensation, acute on chronic decompensation and chronic liver disease. And these are an infection, SBP, hypokalemia, hypoglycemia. It can be use of sedatives, it can be the development of carcinoma of the liver, or it can be just a GI bleed. Another very important question that you may get asked here, and that's the grades of encephalopathy. You need to know the grades, and you need to be able to tell at least a word or two about each one of them. They may also ask you, how do you assess the severity of cirrhosis? You need to tell them you use Child-Pugh score. I'm sure you know it by heart. Finally, the last question they may ask you is about the management of someone with chronic liver disease. You want to divide up your management into 4 steps. So the first step is to stop the insult. For example, if the patient is alcoholic, you want to tell them that you should stop drinking. If they've got autoimmune hepatitis, you want to give them immune suppression. If they've got viral hepatitis, you want to give them antivirals. Second step is to prevent damage from another cause of chronic liver disease, adding on to the original cause. If they're alcoholics, you want to give them vaccinations against Hep B and Hep C. And if they've got Hep B and Hep C chronic liver disease, then you want to tell them do not drink alcohol. Third point is to prevent complications. And how would you do this? You need the patient to be in a surveillance program. For example, for hepatoma, you could do that with scans, you could do that with alpha-fetoproteins. You want to check whether they've got varices, you're doing an endoscopy. You could be giving them beta blockers. If they've had one episode of SBP, then you would be giving them prophylactic antibiotics. The last step is, and this is very easy to remember, is liver transplant. You want to remember the indications, but don't waste too much time to memorize everything about it, because as we always say, the examiner is not a specialist, so even them, they don't know everything about liver transplants. There you go, guys, that's chronic liver disease for you there, and along with many of the other liver problems that can present in an abdominal examination station. If you've benefited from the video, please subscribe so that you don't miss any of the future videos, and also share the video with your colleagues so that everyone can benefit. I wish you best of luck with your preparation and hope to see you soon in our next video. Thank you very much.